Welcome to Nursing 200, Unit 4, Nursing Management of Patients with Immunodeficiency, HIV, and AIDS. An overview of the immune system will be provided at the beginning of this lecture. The immune system is made up of several organs, including your spleen, tonsils, bone marrow, and lymph nodes. These organs make and release lymphocytes, which are white blood cells that are classified as either B cells or T cells. B and T cells fight invaders called antigens. Examples of antigens are bacteria, viruses, cancer cells, or bodily fluids from a sick person. The anatomy of the immune system is that the immune system functions to help the body stay healthy by preventing the growth of infectious organisms and abnormal cells, such as cancer cells. The major components of the immune system consist of the bone marrow, white blood cells, which are the immune system cells that protect from invasion, lymphoid tissue, such as the thymus gland, spleen, lymph nodes, tonsils, and adenoids, and similar tissues in the GI, respiratory, and reproductive systems. The lymph nodes are the thymus, the tonsil, and the adenoids, and other lymphoid nodes. And the reticuloendothelial tissues are the liver, spleen, and any compartment where immune cells gather and work, bone marrow, lung and GI tract lining, macrophages, and neutrophils, which are responsible for phagocytosis. Additionally, lymphocytes, a type of white blood cell in the bone marrow, provide immunity and protection against invasion and infections. The following slide depicts the central and peripheral lymphoid organs and tissues located in the body. Stem cells in bone marrow generate lymphocytes, and there are two types of lymphocytes. The B lymphocytes, or the B cells, are mature in the bone marrow and enter the circulation as precursors to antibody-secreting cells or memory cells. The B cells release antibodies specific to the disease your body detects. The lymphocytes, or the T cells, move from the bone marrow to the thymus, where they mature into several kinds of cells with different helper functions. The T cells kill off the cells in your body that are being attacked by the disease. The following slide depicts the lymphocyte response to invasion of different types of cell types and their functions, and I will allow you to review this on your own. Immune function. There is natural immunity in the body from the mother to the fetus. It protects it from infectious agents present at birth without ever even encountering it. It provides a nonspecific response to any foreign pathogen, regardless of the pathogen's composition. Natural immunity is dependent on the ability to distinguish between self and non-self, and cells involved in natural immunity response include macrophages, dendritic cells, and natural NK killer cells. Physical and chemical barriers provide immunity, such as the skin, mucous membranes, and cilia of the respiratory tract. Inflammatory responses also provide some immunity, as this involves minimizing blood loss, walling off pathogen-activating phagocytes, and promoting formation of fibrous scar tissue and regeneration of injured tissue. Acquired immunity develops as a result to exposure to an antigen. It relies on the recognition of specific foreign antigens, and it's divided into two mechanisms: the cell-mediated response involving T cell activation, and the effector mechanisms involving B cell maturation and production of antibodies. There are two types of acquired immunity, and they are passive and active. Passive immunity is found in breast milk, as the mother's antibodies are passed to the infant, and antiserum is obtained from the plasma of people with acquired immunity and is used in emergencies to provide temporary immunity to certain diseases. An example is that antiserum is given to protect travelers against hepatitis A through passive immunity. Active immunity is provided through immunizations. The immunity does not develop immediately after the first exposure. It takes days to weeks to produce antibodies against the disease. Then, when exposed, immune responses are more rapid and capable of controlling the virus. Humoral immune responses involve antigen-antibody interactions to neutralize, eliminate, or destroy foreign proteins. Antibodies are produced by the B lymphocytes, and the purpose of B cells are to produce specific antibodies to fight against a foreign protein, such as an antigen. Humoral immune responses synthesize and release antibodies such as immunoglobulins, IgG, IgM, IgA, and IgE. An example is on the first exposure, the newly sensitized B cell provides the IgM antibody type against the antigen and ensures that the initial illness, for example chickenpox, lasts only 5 to 10 days. Then on re-exposure, the already sensitized B cell makes Ig amounts of IgG against that antigen to clean and protect the person from becoming ill from that disease again when it's encountered. Cellular immune responses are where the T cells attack foreign pathogens directly rather than by producing antibodies. T cells include effector T cells, such as helper T cells and cytotoxic T cells, suppressor T cells, and memory T cells. Natural killer, or NK cells, are other lymphocytes that assist in combating these types of organisms. Also involves the action of the complement system and helps protect the body through the ability to differentiate self from non-self, such as cancer and transplant organs. Examples of humoral and cellular immune responses are outlined in the chart below. Humoral responses, such as B cells, are present in anaphylaxis, allergic hay fever, asthma, and bacterial infections. Cellular responses, with their helps of T cells, are transplant rejection, graft versus host disease, tumor surveillance under destruction, and viral, fungal, and parasitic infections. Most immune responses to antigens involve both humoral and cellular responses, although only usually one dominates. For example, during transplant rejection, cellular response usually predominates, whereas in bacterial pneumonias and sepsis, humoral response plays a larger protective role. Factors that affect the functioning of the immune system are age. The young and the elderly definitely have a natural decreased immune system, poor sleep habits, smoking, excessive alcohol consumption, and illicit drug use. Nutrition and malnutrition can affect the functioning of the immune system. A serum albumin of less than 3.5 grams per deciliter shows that protein produced by the liver required to keep fluid from leaking out of blood vessels is not present. This protein carries vital nutrients, hormones, and proteins. A total lymphocyte count of less than 1,200 types of WBCs that determine the immune response to a pathogen, and less than 20% of ideal body weight is also associated with a poor functioning immune system. Nausea and vomiting, anorexia, and impaired sense and taste of smell, and food allergies are all a problem with nutrition and malnutrition. Other factors that affect the functioning of the immune system are certain medications, for example, steroids, radiation and environmental or residential exposure to pollutants, and existence of other diseases such as cancer. Question: the protective effects of a vaccination are a result of what immune process? D. Active acquired immunity. Immunization prompts the production of antibodies to prevent against disease when exposed again. Immune responses are then more rapid and capable of controlling the virus. Inflammation, phagocytosis, and cellular immunity do not play central roles in this protective mechanism. Immunodeficiencies. Immunodeficiency is the inability of the body's natural defenses to protect itself from outside pathogens. Primary immunodeficiencies are diseases that are genetic in origin and manifest most commonly in infancy and childhood as abnormally recurrent infections. Secondary immunodeficiencies occur when the body is attacked by an outside source, such as a toxic chemical or an infection, and this affects the normal immune system of the patient, resulting in increased susceptibility to infection and cancer. Acquired immunodeficiency syndrome, or AIDS. There is a link on this slide to a video on YouTube that I think you might find compelling to watch. Acquired immune deficiency syndrome, or AIDS, is the most common secondary immunodeficiency disease in the world. The specific retrovirus causing AIDS is the human immunodeficiency virus, or HIV. HIV is a retrovirus that carries genetic material in the form of RNA, a single strand, rather than the DNA, which is a double strand. HIV is a parasite that takes over cells, which directs immune system defenses, CD4 plus T4, and forces them into making more copies of the virus through a retrovirus means. In other words, the virus replicates in a manner that is in the reverse in the process of human cell division. The epidemiology of HIV and AIDS is that there are more than 1 million persons living with HIV and AIDS in the United States. There are 33 million people living worldwide with this disease. There are 2.7 million new infections each year, and AIDS kills more than 2 million people every year. The greatest age of Infection is between age 21 and 44 years. Most AIDS cases in America occur among men who have sex with other men, MSM. African Americans and Hispanics are affected more. IV drug use, lack of health care access, and education and urban living all affect the epidemiology of HIV and AIDS. This slide shows the prevalence of HIV infection by country. HIV transmission. HIV is a blood-borne, sexually transmissible virus. HIV is not transmitted through casual contact, such as sharing utensils, towels, linens, toilet, mosquitoes, or other insects. Blood and blood products can transmit HIV to recipients. Prevention and education are vital, and the emergence of HIV prompted the implementation of standard precautions and the need for post-exposure prophylaxis. Here's another slide that shows the transmission of HIV and its common routes: unprotected vaginal sex, unprotected anal sex, unprotected oral sex, sharing needles during drug abuse, transmission of HIV-infected blood, breastfeeding by HIV-infected mother, infants born to HIV-infected mothers, using improper sterilized hospital tools, and transplantation of infected organs. Sexual transmission of the HIV virus can be accomplished through genital, anal, oral contact with exposure to an infected semen or vaginal secretions. Gender affects HIV transmission. African American females have a higher risk, and men who have sex with men are the largest number of diagnoses of HIV transmission. Sexual acts affect HIV. Anal intercourse in which the semen depositor is infected is a very risky sexual practice, regardless of whether the semen receiver is male or female. And this is often thought to be due to the thin skin in the anal region that can be damaged or torn during sexual activity. Viral load, or the amount of virus present in the blood and body fluids, affects transmission. The higher blood level of viral load, the greater the risk. HIV transmission can be reduced by A, B, and C. A stands for absence and is the only absolute way to not become infected with the HIV virus. B means be faithful and not have multiple sexual partners. And C is condoms, both male and female, oral and dental dams, and safe sex, including non-intact skin or mucous membranes coming into contact with infected body fluids and blood. HIV transmission. Parenteral, sharing needles or equipment contaminated with infected blood or receiving contaminated blood products. Some communities have needle exchange programs, and all donated blood in North America is screened, but due to lag time in antibody production, up to 6 months, HIV can go undetected, called a window period. Encourage autologous transfusions when possible, which is the reinfusion of blood or blood components to the same individual from whom they were taken. Perinatal transmission can occur from the placenta, contact with maternal blood and body fluids during birth, or from breast milk from infected mothers. About 25% chance of the mother passing on to the baby if not using a drug therapy for HIV versus 8% whom do. HIV transmission can occur across the placenta through infant exposure to blood and vaginal secretions during birth and with breast milk. Again, remember, you don't catch AIDS from a toilet seat, from a handshake, from dirty dishes, sharing a bath towel, or swimming. Question: which of the following scenarios carries the greatest risk of HIV transmission? Answer: a mother with HIV who wishes to breastfeed her infant. Transmission and healthcare workers. Needle sticks or sharp injuries are the primary means of HIV infection for healthcare workers. Workers can also be infected through exposure of non-intact skin and mucous membranes to blood and body fluids. The best prevention for healthcare providers is the consistent use of standard precautions for all patients as recommended by the CDC. The following slide shows a healthcare workers' reminders to maintain standard precautions. Hand washing and hygiene and protective barriers such as gloves, masks, eye shields, and gowns. Do not recap needles and syringes. Clean up spills of blood and body fluids immediately using a germicidal solution. Consider all body fluids to be contaminated. Avoid contaminating the outside of specimen containers during collection, and cleanse work surface areas with appropriate germicide. A 1 to 10 concentration of household bleach is effective. HIV pathophysiology. HIV enters a targeted host, a CD4 plus cell, and the membrane of the viral envelope is fused with the plasma membrane of the cell. Viral genetic material from RNA is copied into double-stranded DNA. Integrated DNA or provirus makes new viral proteins and viral RNA, and new viral particles bud from the cell. The following slide shows the HIV life cycle of the AIDS virus. HIV reproduction. HIV is the specific retrovirus that causes AIDS, and HIV directs the CD4 plus T cell to change their role to be an HIV factory, producing up to 10 billion new viruses daily. As the CDC4 and T cell level drops, the patient is at risk for bacterial, fungal, and viral infections and opportunistic infections. This may proceed slowly if there's no concurrent infection. Antibodies take up to 6 months before they can be detected by a blood test, and this is referred to as the window period, which is the time between initial infection and the development of a positive antibody test for HIV. Generally, positive tests develop between 4 weeks and 6 months, and 20 to 30% of HIV-infected persons develop AIDS within 5 years. Laboratory assessment. Lymphocyte counts have decreased WBCs of less than 3,500, and the normal is 5 to 10,000, and a lymphocyte count of less than 500, with 1,500 being the normal. CDC4 plus T cells are cells that signal to activate the body's immune response when they detect intruders like viruses or bacteria. A normal CD4 count ranges from 5 to 1,000 cells per millimeters tripled. When your CDC4 count is less than 350 cells, treatment is considered, and when a CDC4 count is less than 200, it is one of the qualifications for a positive diagnosis of AIDS. You typically monitor the CDC4 counts every 3 to 6 months to see what the immune response is doing. Here's another slide that shows the T cells, the intruder, and the virus. Laboratory assessment continued. Antibody tests measure the patient response to the virus, the antigen, rather than to measure the parts of the virus. There can be a lag time in antibody production after exposure to HIV, and this is called seroconversion. So negative for antibodies, you should still do a follow-up. The two antibody tests that are used are the enzyme-linked immunoabsorbant assay, or the ELISA, and it's done initially to detect serum antibodies. If the ELISA is positive, then a Western blot is done. The ELISA is inexpensive and it's very accurate. The only drawback is that it may have false negative results in the window period. The Western blot is actually the confirming test for HIV and EAIA results, but it's more expensive and more sophisticated. This slide shows laboratory assessment and the window period of weeks since infection. The first 2 weeks, the patient is highly contagious, however, antibodies may not be detectable. Antibodies appear after 2 weeks, but can take up to 12 weeks to reach seroconversion, in other words, be detectable by current tests. The next test done is viral load testing. Viral load testing measures the presence of HIV viral genetic material, which is RNA, in the blood, a better predictor of risk for HIV progression than CD4 counts. Viral load testing is useful in monitoring disease progression and antiretroviral treatment effectiveness. Typically, if your viral load is high, your CD4 count will be low, making you more vulnerable to opportunistic infections. The goal is undetectable numbers. Antiretroviral medications work to keep HIV from reproducing in the body. This lowers your viral load and protects the immune system. Effects of HIV infection. Everyone who has AIDS has HIV infection. However, not everyone who has HIV infection has AIDS. The distinction rests with the number of CD4 plus T cells the patient has and whether any opportunistic infections have occurred. The diagnosis of AIDS requires that HIV be positive, have either a CD4 plus T4 cell count of less than 200 cells, the normal 5 to 1,000, or an opportunistic infection. Stages of HIV disease. The primary infection is characterized by intense viral replication with the window period. HIV asymptomatic is that by about 6 months, the rate of viral replication reaches a lower but relatively steady state. HIV symptomatic is where the number of CD4 plus T cells gradually falls, and AIDS is where the CD4 plus T cell level drops below 200 cells. Clinical manifestations include the first signs and symptoms that are similar to most viruses, such as influenza, mononucleosis, or viral meningitis: persistent fever, night sweats, chills, headache, painful neuropathies, muscle aches, fatigue, rash, sore throat, and persistent generalized lymphadenopathy, 2 or more lymph nodes 1 centimeter or greater located in places other than the inguinal areas that persist for at least 3 months. Other clinical manifestations include poor wound healing, skin lesions, dry, itchy, irritated rashes, eczema, or psoriasis, neurologic deficits such as paresthesias, burning, pain, gait changes, weakness, confusion, dementia, fever, visual changes, pain, and personality changes. The respiratory system, the patient develops a cough and has shortness of breath, and in the GI tract, diarrhea develops, weight loss, nausea and vomiting, and a wasting syndrome where the patient appears emaciated. The following slide shows the clinical manifestations of AIDS. Opportunistic infections are common in HIV and AIDS patients. The YouTube video link here has a very pertinent video for opportunistic infections that you may want to watch. Infections caused by organisms that are present as part of the normal environment and are kept in check by the normal immune function. Only when immune function is depressed, these organisms are capable of causing infections. There are 4 types of opportunistic infections, and they can be protozoan, fungal, bacterial, or viral. Opportunistic infections do not pose a threat on immunocompetent healthcare workers. Protozoal infections. Pneumocystis carinii or gyroveccae pneumonia is the most common opportunistic infection in AIDS patients. This protozoan infection is found only in immunocompromised people. You assess your patient for dyspnea, tachypnea, persistent dry cough and fever, fatigue, weight loss, and crackles. Treat with oxygen therapy if needed. Diagnosis is done through a sputum culture and transbronchial biopsy. The treatment is TMP-SMZ, which is Bactrim or Septra. Alternative treatment can be Pentam, which is an anti-protozoal if somebody is allergic to Bactrim or Septa. The other protozoal infection is toxoplasmosis encephalitis. It is critical that AIDS patients do not have a cat for a pet, as toxoplasmosis encephalitis is acquired through cat feces or undercooked meat. Watch for subtle mental changes such as headache, fever, speech, gait, and visual disturbances. The following slide shows a chest X-ray of a patient with PCP and the resultant cloudy appearance of the lungs. PCP treatment is aimed at several different types of drugs, and we've already talked about both of them. One of the important things to remember with Bactrim or Septra is that Stevens-Johnson syndrome can develop, which is a redness, blistering, peeling, or loosening of the skin that can be very, very problematic. Fungal infections, such as candidiasis or Candida albicans, produce a fungal infection of cottage cheese-like whitish yellow patches and inflammation. Often referred to as thrush, it occurs in the mouth, the esophagus, the GI tract, and the vaginal area. It's difficult to get rid of and affects nutritional status in most of these patients as it's painful to eat. Treatment for fungal infections of the mouth include the antifungals such as clotrimazole or Mycolex oral troches, nystatin, ketoconazole or Nizoral, or fluconazole or diflucan. Usually topical or suspension treatment for oral candidiasis caused by herpes simplex or herpes zoster. Many of these medications are mixed in an oral suspension and swished and swallowed or swished and spit. Bacterial infections, Mycobacterium avium complex or MAC, is the most common bacterial infection with AIDS. It infects the respiratory and GI tract and spreads systematically. Fever, debility, weight loss, malaise, and swollen lymph glands are clinical presentations of MAC. Treatment, in general, is treated with 2 or 3 antimicrobials for at least 12 months. Commonly used first-line drugs include the macrolides, such as clarithromycin, which is Biaxin, and azithromycin or Zithromax. Other bacterial infections include tuberculosis or TB, which occurs in 2 to 10% of persons with AIDS, and persons with TB and a CD4 plus T cell count of less than 200 may not have a positive TB skin test because of the inability to mount an immune response to the antigen injected. Healthcare providers must follow airborne and standard precautions in these patients in order to not acquire tuberculosis in themselves. Treatment is a complex regime, and up to 6 to 9 months of treatment is indicated. Initial empiric treatment of TB, and the patient is started on a 4-drug regime, usually about 3 to 4 times a week. Viral infections such as cytomegalovirus, CMV, can affect many areas of the body, including the eye, the respiratory, and GI tracts. CMV retinitis is the leading cause of blindness in patients with AIDS. It's painless, blurred vision, or decreased vision, with a fluffy yellow-white retinal lesion with or without intraretinal hemorrhage on exam. Herpes simplex virus, or HSV, occurs in perirectal, oral, and genital areas. Manifestations are more widespread and of longer duration, and lesions are painful, with chronic open areas after the blisters rupture. Varicella-Zoster virus, VZV, or shingles, and this is the virus that causes chickenpox. When people who have had chickenpox are immunocompromised, the VZV leaves the nerve ganglia and enters the body fluids and other tissues, causing shingles. Pain and burning along sensory nerve tracts results, and fluid-filled blisters with or without crusts develop headache and fever. This shows shingles and the cytomegalovirus retinitis. Treatment for viral infections include antiviral medications listed here in the table, and you may review these on your own. Malignancies. Several malignancies develop in HIV-positive and AIDS patients, the one most common one being Kaposi sarcoma, or KS. It's the most common malignancy in AIDS patients, affecting 1 to 21% of patients, and involves the lining of the blood and lymphatic vessels and lesions that develop in lymph nodes, intestinal tract, lungs, and in the skin. These purplish brownish pink skin lesions are normally not painful or itchy, and biopsy of the lesions confirms diagnosis. These lesions are surrounded by bruising and edema, leading to venous stasis, lymphedema, pain, and skin ulceration, and they can lead to hemorrhage or infection. Malignant lymphomas can also develop in these patients: B-cell lymphomas, non-Hodgkin's lymphoma, and often multiple sites of organ involvement happens. The following slide shows the lesions of a Kaposi sarcoma in an AIDS patient. Treatment for malignancies includes surgical excision of the lesions, radiation, chemotherapy, alpha interferon IV-IM or sub-Q, which has antiviral and anti-tumor effects, and the treatment goal is to reduce the signs and symptoms and size and discomfort of the tumors. Other clinical manifestations of HIV and AIDS are HIV encephalopathy, AIDS dementia complex, which is a decrease in cognition, behavioral, and motor abnormalities with difficulty concentrating, apathy, social withdrawal, depression, personality change, confusion, hallucination, and slowed response. And it's a result of infection of the cells within the central nervous system and the cerebral spinal fluid. Diagnosis is done with a CT scan, which shows cerebral atrophy, ventricular enlargement, and an MRI, and a lumbar puncture can be done to analyze the cerebral spinal fluid or a brain biopsy. AIDS wasting syndrome results from the altered metabolism from cancer or infection and is a syndrome that is characterized by diarrhea, malabsorption, anorexia, oral and esophageal lesions. And also, many skin changes can develop in the patient: dry, itchy, irritated skins, rashes, folliculitis, eczema, or psoriasis, and when the platelet count is low, petechiae or bleeding gums may be present. Antiretroviral therapy is important in AIDS patients, as ART uses different kinds of medications to keep HIV from growing and multiplying. Antiretroviral therapy can help patients live longer, lower the risk of developing non-related HIV illnesses, and reduce the chances that they will transmit HIV to others. The HIV life cycle is presented here, and it shows where different types of ART therapy work. Antiretroviral pharmacological treatment includes nucleoside reverse transcription inhibitors, which are used to treat HIV infection when the CD4 count is greater than 500. Pharmacologic treatment also includes protease inhibitors that alter and inactivate the HIV-1 and HIV-2 viruses by inhibiting enzymes needed for HIV replication. The specific medications, their side effects, and their nursing interventions are listed in the charts, and I will allow you to review those on your own. Other pharmacologic treatment includes fusion entry inhibitors, which prevents HIV infection by blocking the ability to fuse with the host cell. This prevents the virus from ever entering the cell in the first place, and almost 100% of patients who use these have injection site reactions. Also, the non-nucleoside reverse transcription inhibitors act directly on the reverse transcriptionase to stop HIV replication in the RNA, and the common side effects of these medications include a rash. Antiretroviral therapy only inhibits replication and does not kill the virus, and treatment with only one antiretroviral agent promotes drug resistance and does not improve duration or quality of life. Cocktails are multiple drug regimes of 3 to 4 HIV medications from at least 2 different classes of antiretrovirals show good results as measured by reduced viral load and improved CD4 plus T cell counts. Each medication attacks HIV at different stages of the viral replication process, and HAART is highly active antiretroviral therapy is critical in patients. There are many different numbers of drugs. Food and timing requirements, medications should be given with meals or on an empty stomach or not being taken together. And this is a lifelong regimen that can be very burdensome, so counseling and quality of life and cost issues need to be discussed carefully with the patient. Antiretrovirals terminate viral replication, block DNA activity, inhibit and prevent maturation of HIV, and their drugs are like the CIA. They search for the virus, they work to interrupt and hinder growth, but they aren't able to kill totally. The retrovirus is like a terrorist who takes on different shapes and forms, which fools antiviral agents. The following questions will be discussed in class. Nursing interventions, the patients with AIDS. Priority nursing interventions for the patients with AIDS are promoting skin integrity, promoting normal bowel patterns, preventing infection, improving activity intolerance, maintaining thought processes, and promoting airway patency. Impaired skin integrity, from Kaposi sarcoma, herpes simplex virus, and diarrhea. KS, treated with local radiation and chemo, analgesics, repositioning. Domboro soaks can prevent healing and relieve pain. Keep lesions clean, dry, and dressed, and cleanse with normal saline once a shift and let air dry. Avoid scratching, non-abrasive, non-drying soaps, and non-perfumed skin moisturizers. Avoid scratching, but make sure you don't have non-abrasive, non-drying soaps. Impaired bowel elimination, diarrhea, usually from medication side effects. Lactose intolerance worsens with HIV. Lomotil and Imodium can be given on a regular schedule. And octreotide or sandostatin inhibits GI motility and intestinal secretion of water and electrolytes and is often useful with diarrhea from side effects of medications. The patient may need less spicy, fatty, or sweet foods, and no alcohol or caffeine. Sometimes eliminating dairy is helpful, and smaller frequent meals are also important. It's important to assess the perineal skin and apply creams or barriers if needed. Imbalanced nutrition, less than body requirements, fatigue, anorexia, nausea and vomiting, painful swallowing, diarrhea, and wasting syndrome or cachexia. You need to remember to offer the patient high-calorie and high-protein foods and avoid fats due to intolerance from disease process and side effects of some of the antiretroviral drugs. Small frequent meals are very important, and the patient may often be prescribed megestrol acetate or Megase as it promotes weight gain. Marinol, a synthetic marijuana, is thought to relieve nausea and vomiting in some of these patients. Thoroughly washing off fruits and vegetables is important, vitamin supplements, tube feedings or total parenteral nutrition, and judicious mouth care using viscous lidocaine, a soft toothbrush, or sodium bicarbonate with normal saline every 2 hours. Disturbed thought processes. Psychological stressors develop from HIV infection and organic disorders from opportunistic infections, cancer, or HIV encephalopathy. Clear, simple language is important. Allow sufficient time for client response. Reorientate often using calendars, clocks, radios, and simple directions. Post daily schedules. Drug therapy often consists of psychotropic drugs and antidepressants, and safety measures such as environmental and seizure precautions. Other nursing diagnoses: pain. Pain develops from enlarged organs, stretching the viscera, or compressing nerves, tumor invasion of the bone and other tissues, peripheral neuropathy, and generalized joint and muscle pain. Warm baths, pressure-relieving mattress pads, massage, heat, or cold are often helpful. Nonsteroidal anti-inflammatories can be recommended if there is an underlying bleeding problem. Medications such as Elavil or amitriptyline, which is a tricyclic antidepressant, often are used. Prozac alleviates fatigue and lethargy associated with depression, and opioids can often be used in combinations that are helpful to the patient. The management of cancer relief pain with guide to opioid availability is shown here in the three-step ladder. For mild pain, aspirin, acetaminophen, and NSAIDs are with a plus or minus an adjuvant. In moderate pain, APAP with codeine, APAP with hydrocodone, oxycodone or dihydrocodeine, and tramadol. And for severe pain, morphine, hydromorphone, methadone, levofenorol, fentanyl, oxycodone, and adjuvant. Chronic low self-esteem is often encountered in these patients, so allowing for privacy when needed, counseling, and guided imagery are often important. These patients are often socially isolated, so promoting interaction with others, showing empathy, spending time talking with the patient, encouraging patient to talk about their feelings is critical. Community-based care. Home care management. Case management for home care for these types of patients includes drugs, nutritional support, terminally ill plans, finances, insurance, legal services, funeral arrangements, and spiritual counseling. Health teaching is important for the patient. Teaching patient, family, and friends is a high priority when preparing for discharge. Transmission and infection control needs to be reviewed, reminding the patient not to share razors, toothbrushes, or any potentially blood-contaminated articles with other people in their household. Safe sex practices need to be reviewed, and the avoidance of large crowds and avoid cleaning pet litter boxes is important for the patient. Balancing rest and exercise is important. Avoiding raw or rare fish, fowl, or meat. Thorough washing of fruits and vegetables, and proper food refrigeration techniques are also included. Safe administration of meds and side effects also need to be monitored. Psychosocial preparation is the social stigma and a rejection that's associated with AIDS and HIV. Identify coping strategies for the patient, continue usual activities, and mental health and behavioral health professionals and support groups are also important for these clients. Healthcare resources need to be reviewed with the patient, such as community peer support groups, clinic services, respite care, home IV therapies, Meals on Wheels, and other internet resources. The following questions will be reviewed during class.